Honorable Chape.
Thank you, Chair. Just as a new member, it might have been helpful to have had the presentation before so that we could go through it. I know that we didn't exist as a committee, but I hope that going forward we'd be able to get the presentations before they are presented here so that we could look at them and maybe even start asking some questions before we meet. And something that is conspicuously absent in the report, maybe it was done in the previous period, is something about COVID-19. Since we've just come out of COVID-19 with devastating consequences to our health system, and there were strategic decisions that were taken about closure of schools, vaccine programs, wasted vaccines that were not used, national immunity, contact tracing. I think it's an important thing that we would hope the department would report on so that we prepared for next time. And that as the international health regulations are revised, we are alerted by the department as to whether we are prepared for those changes and that as a nation would be fit for purpose. I also have a question just in terms of the NHLS was mentioned in the report, and we've had a security breach at the NHLS, which has a devastating impact on patient care. Just in terms of what is being done in that regard, in terms of preparedness going forward, given the restrictions of the PFMA in terms of ransomware, and what have we learned and what are we going to do to ensure that our systems are more resilient, particularly on the recovery side, because the attacks will continue to occur going forward. It's about our preparedness to deal with those. There's an issue that has been put through by both the DG and the CFO about invoices paid within 30 days. And that's remarkable. But where the rubber hits the road, does that occur? When you pass on money to provinces, do you measure how they perform in that regard? I sit in a province where the third largest hospital in the world was not paying its telephone accounts. So Barra's phones were cut with disruption to services. They can't have been cut for not paying on 32 days. So how do we measure that at a provincial level? Because that's where the interface and service delivery occurs. There'll be other issues that we would engage with going forward. For example, accreditation for providers. Are you accrediting them or are you contracting with them? Is it contracting for providers? So that there should be clarity about how you interface with the other statutory bodies that are accredited. Because if that function is taken over, as a practicing doctor, it would save us fees to the HPCSA if the department has taken over accrediting professionals. The TB. Just to link to what the honourable member was talking about, what are we doing about prevention? Because I have the sense that in South Africa, we have habitats that are great incubators for a disease like TB, where overcrowding is the norm. We have informal settlements, no ventilation, people living on top of each other. Do we treat them, take them back to those habitats and hope we'll be able to eradicate TB? How do you interface with other departments on those issues? Lifestyle diseases. That's about personal decisions that you make. Do we factor in environmental factors, governance issues, societal factors that influence lifestyles? I mean, I grew up in the township and we had lots of sports fields. So as we grew up, when our parents were working, we could occupy ourselves with playing soccer. You go to Soweto now, there are no open fields. And the kids are in the street doing drugs. Those spatial arrangements in terms of things that have a health impact that are influenced not just by lifestyle, but also by the environment that we live in. And a question that might be of a personal nature, the issue of GBV and femicide, is there a health lens to it? And if so, where and how do we look at that. A question that has come up from the House has been about accountability of provinces, how we can do oversight, access to facilities at a local level. When you go back home, can you go to a clinic? How do you do that? And a lot of members have been reporting being refused entry to health facilities. How can we deal with that aspect? The issue about drug distribution, the medicine parcels, PUPs, is it an outsourced program or is it insourced? Because I'm just concerned about our inability to rebuild public service, where instead of rebuilding services, we outsource them. I mean, in Gauteng, instead of rebuilding oncology services, they want to outsource them at twice the cost from the private sector, when we should be rebuilding issues. Has an assessment been done about the impact of non-compliance? I mean, we have a few old ladies in our family, and some of them are stockpiling medicines. Because they have them, there's no advice, they decide what they're going to use, what they're not going to use, and they end up stockpiling medicines. Is there something that is being done to look at the issue of compliance, utilization, and recovery of medicines that have not been used? The Fiscal Commission spoke to us, and as a new member, they're talking about, are we spending our money in the right places? Has there been a discussion between Health and the Fiscal Commission as to, are we spending our money in appropriate places, or can we do better? The issue of litigation as a rising cost. Is there a plan of action in terms of how we're going to deal with that aspect? Because there's low-hanging fruit in terms of what can be done. No fault compensation. The issue of, if you came to a public healthcare system for your care, if you have an unfavorable outcome, your future care would still be with the public healthcare system. So why should there be a large payout in court for future healthcare costs? Issues like that, looking at legislation around that issue, because it's becoming a rising cost going forward. RWAPs, destroying the training platform, where people take full-time salaries and run full-time practices. Isn't about time that we make a decision? Because the people that will tell you that if you take away RWAPs, they are going to leave. They've already left. You're just paying them. They're basically like glorified ghost workers. And that issue, I hope, will be dealt with as a health emergency that it is. The IT platform. If you look at our expenditure post-94 on IT and information systems at province level, etc., we spend an inordinate amount. Can we come up with a coherent national plan that will be for all health encounters? Not that Gauteng has its own little scheme in its clinics, KwaZulu-Natal has it. I mean, we're the same people. If you have an idea and a smart card, we can make sure that things are centralized and the department leads. Second last thing, on lifestyle, things that are related to behavior. Are there any plans to balance the pharmaceutical model with a model of improving people's behavior? We're doing the right thing. We're providing PEP. We're providing PrEP. But HIV is a sexually transmitted disease. What are we doing about preventing new infections? Not just reliant on pharmaceutical products. So for me, the last issue is oversight. As the Director General and the CFO said, you get lots of money, but most of it you pass on. How do you keep those that you pass the money to accountable? When we're talking about maintenance at a national level, does that truncate to how it should be done at the front line? Are we going back to having maintenance department in hospitals? When a tap is leaking in a hospital or in a clinic, where do we go, Chair, for that? Isn't it time that we begin discussing health being a national competence? I thank you, Chair.
Welcome, Minister Mzwaledi. I welcome the enthusiasm of Honorable Dr. Letlape. I noted 11 of your comments coming through. Half of those the Minister was getting into, so he probably will come whenever he wishes on those 5, not on the ones Minister you don't know. The fortunate member who's also going to listen is the last member, Honorable Dr. Tembegwayo. It's your last, is the last member to input. Thank you.
Thank you very much. Greetings, our Minister, and thanks for the presentation then. My starting point is based on the induction that we had last week, where the theme for the 7th Parliament is transformation, which obviously means transformation should take place in all departments included. That's what I think, which means we can't go on a repeat of doing what we were doing in the 6th Parliament, the same, and expect us to say we have transformed within the department. It can't be like that. And most important, that within the principles that were mentioned there was the maintenance of public interest. And I'm just going to apply and raise a question on the slides on page 4 as compared to page 6, where in page 4 there is under key focus areas for 2024-2025 accepted that community engagements to promote participation and aid responsiveness to health needs. Yet on page 2, under program 1 for administration, you have health promotions and community participation, number of community engagements on health programs allows it to. I think we have to relook on that. If we want a proper participation of communities, then it can't be true. It can't be 2. It has to be a better number, but it has to be improved from 2 to something else. And still on the same page where we talk about the employment equity targets, for transformation's sake, we can't be happy and accept that only 2.5% is the one that is given for people living with disabilities. I think we have to change, because 50 is women, 30 is youth. Why is it 2.5% only for the people living with disabilities? For the transformation, can't we up the percentage for the people living with disabilities, taking into consideration a number of the people who are disabled in South Africa vis-a-vis the percentage that we would like to use on the thing. The second question is based on the alleged bid rigging that was mentioned in January 2023 in the 486 million lease for the department's new office. We need an update on that, even though we know that it's an investigation based on the court, but you can take us into confidence and just tell us on the proceedings at the present moment as they are pertaining to this matter. Very important, when you go out on oversights, whether it be an oversight in the province, whether it be an oversight in an unfortunate incident of a hospital, say the hospital has burned, and so on and so on. Like I'm saying on transformation, how are we going to, say for an example, we went and we meet with the minister's department, we say to them, this is the situation. How are we going to work together in improving whatever the unforeseen circumstances can be derived from the oversight that we could have done as a committee, so that we don't only go on an oversight, we have our own recommendations, but the recommendations does not speak or are not addressed by the department itself. Because we also, when we go on oversight, we also have representative from your office. And then how are we going to go about addressing such issues? The following one is about following the assassination of Babita Dekran. The one is an unfortunate occurrence. We usually ask to say, how is your department protecting the whistleblowers in health sector? It's not clear enough and explicit enough on the plans and the projects that are in place to protect the whistleblowers. How do we plan to close gaps for corruption practices? There are a lot of corruption practices that are happening. How do we plan to close that so that we move on a clean plate? If something is reported, if a corrupt or a corruption matter is reported, how do we conclude it in such a manner that all of us are satisfied with the outcome thereof? And lastly, how do you intend to address the committee recommendations on the findings arrived at from oversight, including the recommendations from the Auditor General? We usually have negative results or reports from the Auditor General, but each and every year there occur the same mistakes and nothing is being done. And especially when we find that the mistakes that are done by the department itself, I mean the National Department of Health, having some negative information that are derived from the Auditor General. We have to do things differently in this period, for this fifth-year period. And please, can you be able to update us on that? That was the last question, Chairperson. Thank you.
Thank you very much. May I also add, you do allow chairpersons to also add in the bag of questions. Maybe let me take in from where Dr. Tembeka has left off. There was a report of the oversight visit of this committee to the Eastern Cape Department of Health. It even served in the House. I don't know the processes of getting that being attended to. But just for our sake, I would request that if that report can just be given to the new members, because linked to that has been about 4 members mentioning that would like to do oversight to provinces. Now, we don't ask anyone to do that. You just make a plan. So it will be within our own arrangement. The province that I remember the community visited very well was the Eastern Cape, and the report that we brought back from the Eastern Cape merited a tabling in the House, and it was part of a debate in there because there were certain concerns therein. So I would really want to say it is within our own decision to visit provinces as oversight. We would actually inform the minister, get his support to go there, but not that we need to really make a special request that we want. Because we are citizens of the country, we do pick up challenges here and there, and therefore, as part of oversight, we should therefore make that plan. I'm raising this because I think 3 other members have raised the same point of oversight visits to provinces. My other comment on page 3, but let me commend the department firstly for we are one of the few departments who actually bring a presentation number 1, 2, 3, 4. It's easy for us to make reference to say, can we look at slide number 10 or whatever, because you are actually namely. Now, slide number 3. You are talking there about the 10 pillar of the Presidential Health Compact. You would recall, I've always been commenting, and I will always continue to say, the 9 other pillars are supposed to be really the hymn song of the department, because those are our enablers of not only just universal health coverage, but of the health system strengthening. I was listening to the minister this morning on the TV mentioning all of the 10, and he was picking up on these 9 pillars to say, talking about leadership, finance management, infrastructure. Now, we would like, because that is your plan of really taking us into the new, better world of universal health coverage. Let's hear you talking about it, and let's see it being done continuously. And there's been a first Health Compact 2018. Last year there was another one, again, to look at how far. That is when you added this 10th pillar. Now, let us not really wait. Let's hear you to say, today we are just sitting at the Department of Health to evaluate ourselves and tell the country where are we with the 9 pillars, now 10. Please, let's do that, because that is one other way of adding confidence to the South Africans that what you have put in as a plan going forward will actually do work, and then we'll be really happy about that. I want to also join my honorable members when they're saying your report, Shenge, did not have a baseline. On slide number, I think 7, you are talking about wanting to improve on the CCMTD to 9.5 million. We don't know what's your number, what's your baseline, what is what you had last year. So we want to go to 9.5, coming in from what figures? There was once upon a time 1 patient, 2 patients, 3 patients. So it would be important to say right now we are really going for 9.5, because last year we ended at about 7 million or whatever number. So with all other members mentioning that it's difficult to really talk about we are going to 9.5, but where do you come from in terms of your previous performance? Now, I was listening to you very carefully, TG, and the words you used, electronic medical records, very soon. I was not impressed with very soon, because very soon is as good as very long, very short. Now, I don't know what is your very soon. If you could really assist us to quantify this very soon, even if you are not truthful, hopefully you will be truthful. Just give us some sense of confidence as to where are we going with this process. One is aware that we are underplaying your successes on HPV, and it's a very important program that we need to talk about, and let's hear more about certain things that we have done on these issues. Let me just see on the last one. It would be important in your slides and some of your efforts. Honorable Dr. Letlape talks about TB prevention. And if you do not up your game, and I know you are trying, in terms of TB in the mines, because that's where sometimes you find a TB mine worker who actually goes home undiagnosed, and the TB that he has picked up in Rustenburg goes to Lusikisik. And therefore, the whole community that otherwise they never had TB has received TB. So we would also want to say that TB in the mines should also be coming in. Probably it was assumed that it is part of your story, but we do not really get that part of it very well strongly. The last one from my side. The 5x5, I will always shout it even though one is not in that space anymore. You see, 40 years ago, there was a professor who used to teach and say, if you want to look for hypertension, diabetes, in Durban, we must go to Chatsworth or Durban North, because that's where there was a community of white community and an Indian community. Now, 40 years down the line, epidemiology tells you if you're looking for hypertension, diabetes in Durban, it doesn't matter whether you go to Durban or Wamash, the same place has got the same. So it means we are actually getting to a space where non-NCDs, hypertension, diabetes, are going to be a new pandemic under our face. We really appreciate your strides on issues on TB, HIV, and continue with that. But we just don't think, and I also have been saying it while I was there, that I don't think as a department we are pulling all the efforts in pushing for NCD to be our new pandemic that we say this is going to be hitting us very much so, and we need to do something about that. So we will give you comments, space to then reply to us. Colleagues, just to remember, we should be wrapping up the latest 10 to 3 in this hall so that we leave, allowing other meetings to take place. Back to you, DG, and your team. Minister also. Sorry, okay, ma'am. Yeah.
Thank you, Chair, and my apology for speaking after you. I've forgotten to raise this issue of the allocation of funds to the provinces. Looking at the presentation done by the CFO, provinces like Limpopo, Mpumalanga, Northwest, and Northern Cape, they've been allocated a smallanyana amount, but those provinces are the one in need of health services. They are scattered. Some they will go for a month without a mobile clinic, let alone a physical structure. So my appeal is to reconsider the allocation of funds to the smallanyana provinces. Thank you, Chair.
Thank you very much, Honorable Chair and Honorable Members, and greetings to my Minister. I've got a team that's supporting me. I'll start with, from planning, I would like Kokeso to deal with the issues of the baseline. Also talk about the annual report, which is still to be tabled in this committee in September. That will give most of the information of the performance in the previous year, including the audit, and all the issues around the indicators. Kokeso, you will deal with that one. When Kokeso is done, I'll request the CFO. CFO is going to deal with all the finance-related matters, allocation, the audit, how do we monitor, how do we implement the audit findings in terms of the audit plans, and all finance-related. When he's done, then I'll request Professor Crisp specifically to deal with there's a number of issues around CCMDD that came up, but I'd also like him to just to talk a bit about the Health Sector Anti-Corruption Forum that he participates in terms of fraud management within the health sector, not only in government but also in the private sector. I'd also like him to talk about COVID, the number of issues as he led that program in the department. There's quite a number of questions that came from the honorable members that I'd like him to touch on. I think, and then I also talk about digital health, information systems, electronic medical record, and then I'll take all the others before my minister comes in. Thank you very much. Over to you, Koketo. We have a very limited time.
Thanks, DG, and thanks to the honorable members for the valuable inputs. In terms of the comment around the baseline, we have noted that going forward in terms of also highlighting for the honorable members to be able to make a comparison. Just in terms of touching on the 3 that were mentioned of interest, in terms of life expectancy, it was, before COVID, it was 65.4. And it took a knock during COVID, and now we have improved. It took a knock to 59.2, and now we have improved to 62.8. And the one on the CCMDD, we are currently sitting on 9 million parcels that have been distributed to the pickup points, and we are going to therefore ensure that we accelerate that to 9.5 million. In terms of the employment equity targets, we are guided by the targets that have been provided by the Department of Youth, Women and Children. people with disabilities as far as the aspirational targets for 2030 in line with the NDP. So we are working progressively towards those targets. So on a year-to-year basis, we do look in terms of how we have managed to work on those targets and see how we can improve towards the 2030 targets. Thanks, DG.
Thanks, CFO.
Thanks, DG. I will really appreciate the comments that we received. So I will also provide the clarity on some of the questions. There was a question relating to why the budget has been decreased in terms of the COE at the National Department. So when we received the budget allocation from Treasury, they did indicate how much has been allocated. And based on the allocation in the current year, it was less than the allocation that we had in the previous year. So in the allocation letter, Treasury, they will say the total amount of so much, which is the amount that I've indicated, is specifically and exclusively appropriated, which it means from Treasury point of view, that money cannot be increased without the approval of the National Treasury. So then it means as a department, we cannot spend in terms of the compensation above the money that has been allocated by the Treasury. So that is the reason why that money has been decreased. So in terms of the comments from the honorable members, the money of 15.9 million that has been decreased in the COE, that money it's only for the staff at the national office, which is to support the programs which the DG has presented earlier. So it does not include the appointment of staff in the facilities, which is the doctors and nurses. So now when it goes back to also the question relating to the budget, in terms of the baseline, but my colleagues have already indicated the issue of the baselines. So in terms of the allocation of the budget, maybe just to briefly, Honorable Chair, just for a second. In the previous financial year, we had 60.1 billion allocated, which is the last financial year. Then during the adjustment, then the department, they've suffered a reduction from National Treasury of 1.5 billion, which a billion was coming from HIV and AIDS, and 440 from the Revite, and also 205 million from the National Department in terms of the allocation from the voted funds and the allocation to the other entities and NGOs. Then in terms of the indicative figure, how much we then were supposed to get in this current financial year, in terms of the documents, it was 62.4 billion. That's how much we were supposed to receive. So based on then the revised allocation from National Treasury coming to the current financial year with the actual allocation of 62.2 billion, and therefore hence we indicated the overall reduction of the budget in the department with 225 million. So that is the reason, but in terms of the details, it will follow what the Koketso has said in terms of not showing the baseline, but all that information is, I think it will be available. And also the comment in terms of the allocation of funds to the provinces in terms of the conditional grant, because the money that we allocated to the province, it's not the all money that the provinces they have in terms of provision of healthcare services in the provinces. So the total allocation for the sector, when you compare with, or when you take into account the allocation to all provinces, is about 259 billion. So that includes the 56 billion which I have indicated or we have presented in this committee. So then the other funds which are available in the provinces, then they use in terms of the provision of the services in the provinces. So in terms of the other relating to monitoring of the provinces, more especially on the conditional grants, is based on what the DG has said, that there is framework where the provinces, they will do the business plans which they have been approved by the DG. Therefore, as a unit, we have the responsibility to do the monitoring of the spending in terms of the agreed business plans, to make sure that the provinces, they spend in terms of that agreed business plans. And also the provinces, they will draft the annual procurement plan specifically for the conditional grants, but then they will have the separate one for other sources of funding. We do the provincial visits, we do the quarterly reviews in the provinces in terms of the spending for the conditional grants. It also talks to the issue of the audits. How do we monitor? We do have the CFOs forum where we sit with all the CFOs from the provinces, where they also compile all the audit action plans. We go through the plans. We do assist the provinces, even in terms of the technical issues that they will have with the AG, where we have also established the 3x3 with the AG, where we come together and discuss some of the technical issues which the provinces then they do suffer during some of the processes. I think the issue of the medical legal, maybe DG will also be able to elaborate more. I think the other questions then they were actually the same, which I've cleared. Thanks, DG. Oh no, thanks. DG has just reminded me the issue of invoices, because I did not indicate it here. In terms of the invoices which the honourable members they've asked, I can indicate, Honourable Chair, to say in the department currently, the payment of invoices to service providers is less than 10 days on average. But however, we will have some of the instances where then the suppliers, they are paid over 30 days. Those becomes where either we still reviewing the invoices, or sometimes we'll find the invoice, it doesn't tally with the order, or maybe there are issues with the banking details and so on. So in the current financial year, the reason why we had a number of invoices which were paid after 30 days, so they were relating to medical legal, that the national department was supporting the provinces in terms of dealing with some of the medical legal claims. So some of those invoices which then the national department was paying in terms of the provinces, that's where there was a number of invoices which were paid within, after 30 days. Thanks, DG. Thanks, Jim.
No, thank you very much. But also just to mention that the zero is referring to the National Department of Health. But also just mention that the provinces have their own APPs that they also put into the provincial legislatures with their own provincial targets on how they deal with matters. May I request Professor Crisp to come in?
Thanks, DG. And good afternoon again, Honourable Chair, Honourable Members and Honourable Minister, colleagues. So the DG asked me to address a number of the issues. So I'll start off with the medical legal issues. There's a health sector anti-corruption forum that's working hand in hand with the National Department, and the National Department has a working group together with the provinces working on medical legal issues. So what it would be useful for honourable members to know is that a large proportion, we don't know the actual percentage yet, but a large proportion of medical legal claims are absolute fraud. And at the last meeting of the Anti-Corruption Forum on the 28th of June, which I attend, we went into great length dealing just with the medical legal investigations. And there are literally hundreds of lawyers who have been reported for fraud. There are at least 70 people who have been charged with criminal charges in terms of Section 17(2) of the Health Act for being illegally in possession of patients' records, and there are over 3.5 billion rand. We will put out a formal report of monies that have been prevented from being spent because of the interventions of this forum, particularly the SIU and the NPA. There are other actions still going on at the moment. So just in terms of the medical legal controls, that's one of the actions. There's also, as I said, an activity going on between the National Department and the provinces on monitoring medical legal claims, because what happens is that claims are lodged in more than one province. A patient might be seen in a clinic in Mpumalanga and a hospital in Gauteng, and then they'll lodge a claim around that patient's condition, or sometimes there's not even a condition, and in some cases there wasn't even a patient, but they will be lodged by the lawyers in more than one place, and it's taken cooperation in the forum between the departments to try and uncover what is going on. There's a case management program that's happening there. Related to the medical legal cost, there's another issue which was raised by honourable members about, where we pay, and I think it was Honourable Letlapi who asked about the litigation and no-fault compensation and so forth. There's a review of a number of pieces of legislation that's been underway for a while. The one is the State Liability Act, where the Departments of Health have been pushing to get an amendment to the State Liability Act so that the provinces are not going to pay upfront for instance, 30 million rand, and then the money sits in a lawyer's account and 8,000 rand a month gets paid out to the patient. So we've been fighting that, and there was a case won in the Eastern Cape, which has now set precedent, which shows that we do not have to pay it all up front on the contingent liability space. But that's not finalized. There's not been an amendment yet to the State Liabilities Act, and we continue to interact with the Department of Justice on that process. There's also a review that's been going on from the Law Reform Commission into the way in which all legal cases are happened in the health sector, and not just the public sector, public and private sector. And so the issue of no-fault compensation is raised in that report. It's a very substantial report. The Law Reform Commission does not like no-fault compensations, and they have a range of other options that they are looking at. That we've had meetings with the Law Reform Commission as the department, and there's ongoing work with them. But these reforms have far-reaching implications into many pieces of legislation, so it's not going to be finalized in a short space of time. The last issue related to the medical legal, and I think the Honourable Temba Kwayo asked about whistleblowers and so forth. There's a project recently being concluded together with UNODC, that's United Nations Office of Drugs and Crime, who are working with us. This program looks specifically at how to deal with a whistleblower program and with the management of reporting of crime and corruption that goes on within the health sector, particularly in the public sector, but also in the private sector. That program report, as far as I know, is concluded, and there was a discussion at the Anti-Corruption Forum on the 28th of June about rolling out further to other provinces based on what was learnt in the Free State. And there's also a meeting tomorrow where we will be meeting again, where the UNODC is going to provide some support to us in setting up our framework for anti-corruption and fraud prevention in the National Health Insurance. There's quite a lot of work going on in that space. I think that covers all the medical legal questions. The second set of questions are around the electronic medical record. So where we are at the moment is we have what's called the minimum viable product of the first phase, or the first module, if you like, of the electronic medical record is finished. It is under field testing in the Free State at the moment, and we have presented it. We've done a video presentation to the National Health Council to show them what's in it. It concentrates on the HIV and TB data collection in this first module, mostly because there are a lot of parallel systems that are largely donor-driven that are causing great difficulties for us to collect data in that space. And it's very difficult to manage a patient with HIV or TB who also gets pregnant and then gets other illnesses because their data is captured in these vertical silos. But the second phase will deal more with what we learned during COVID and vaccinations, the EVDS work that was built onto the NHI's database, and we've already had interactions with the Child and Health part of the National Department of Health that we want to start preparing for the next phase. So we're hoping that by November we'll be ready to roll out this first November this year, I'm talking about. The first phase testing, which we're busy with at the moment, will be ready for rollout, at least in one site in each of the 9 provinces. That work is happening. It will not address, just to moderate expectations, it will not address all the backlog hospital records. It will not address all hospital records in all hospitals in one space of time. You can imagine that is really expensive, and it will not replace all the existing health records that are captured in the provinces. What it will do is create the common record that we will all use going forward, once we are registered on the HPRS and each have, that's the Health Patient Registration System, and each have that unique identifier. Then when you go to any accredited provider, the provider will open your file using your own ID and your own fingerprint to get into that record to continue your care. So it's a long project. It's very big. It's got a lot of developers working on it at the moment, and we only have enough money to do it in pieces. Related to that, I think, is the question of the accreditation of providers that Dr. Letlape asked. So we must make a distinction between different words. The Office of Health Standards Compliance is responsible for certification of standards in providers. The professional councils are responsible for registering professionals and making sure that they remain registered, current, and safe in their practices. None of that changes. Accreditation is where the fund finds that a provider is both compliant, their individual providers inside the establishments are registered, and then that they comply with the benefits package, the formulary, the digital systems, etc., before they are allowed to contract with the fund for public money to be paid to them. So we are very happy that we're working with all the different players. There's no duplication of any of the systems, and the way the system is designed is to go and, if you like, we talk about pinging. It goes and it looks for the provider on the provider registry, whether it's the Nursing Council or the HPCA or wherever. So we can come back on a subsequent presentation and give you feedback on what that's about. Okay, the next issue that was DG asked me to talk about is COVID-19. So today we didn't speak about COVID-19 because this is the plan going forward, but I guess what Dr. Letlape really was at was what happens if there's another pandemic? What did we learn and what are we doing about it? And there are a number of issues which are in the plan, but they weren't specifically addressed, Chair. For instance, we have a program going on antimicrobial resistance, and there's a One Health program that's been driven globally that we are part of. We are working together with a number of other departments, especially environmental affairs and agriculture, because antimicrobial resistance is not a massive problem in humans at the moment in South Africa, but it's a very big problem in the agriculture department, where antibiotics are freely available and put into feedlots and so on. So that program is a global program, and we are part of the Africa program and of the global program. Also related to what we learned during COVID is what we are doing with vaccines and other products, but mostly vaccines. And there's a collaborative in Africa to improve our capabilities for developing and manufacturing vaccines for Africa in Africa. And South Africa is a big player there because of Afrigen in the Cape, BioVac, which has got it's a partly government-owned facility, which has a lot of capabilities. So the networking that is going on is very significant, but there are global players that we have to take into consideration. And yeah, so we take part in the United Nations processes related to international body for negotiating in that space. I think the last one I was asked to talk about is the CCMDD. There were a number of questions related to this. So the way in which it works at the moment is that the chronic centralized medicines program was originally developed as a donor-funded program for HIV and TB to get antiretrovirals distributed to patients who are already stabilized, but to distribute them outside of health facilities, so decongest clinics and outpatient departments. It has outstripped its initial value, as I think was presented, which there are chronic medicines that are being distributed as well as other chronic medicines as well as antiretrovirals now. The problem is that the program grew so fast that it is not fully funded all the time. And so we have had a program running for the last 12 months, trying to understand exactly what the line of development can and can't be. And there are moving parts. For instance, shifting scripts from 1 month to 3 months and from 3 months to 6 months and so on have impacts both for the patient and for the facilities and for ordering of medicines and for distribution. At the moment, the distribution network is on contract. The price has been brought down dramatically by renegotiating the contract on multiple month dispensing, and there are pickup points that are both in facility and out of facility. And the pickup point, whether it's at a small shop or whether it's at outside a pharmacy or whatever, they get paid, but the ones that are in public facilities obviously don't get paid. Now, not all, there was also a question about baseline. So the baseline, that what we've done is we've shifted the target now not to the numbers of people, because every year we were just saying, this is the total number of people who've been registered. And that doesn't help, because people leave, people die, new people come on, and so on. So what's more important is how many are actively on the system. And there are about 2.7 million people actively collecting medicines every month on the CCMDD program. So you can imagine the impact for those people. They collect parcels, and we monitor the numbers of parcels now, because some of them is not monthly anymore. It's now 3 monthly, or some 2 monthly, and there were during COVID 6 monthly. So we are trying to stabilize the number of parcels and where those parcels are collected, and we are monitoring the number of uncollected parcels. That goes to Dr. Letlapi's question about what do you do with unrecovered medicines. What we can't see is into the household of non-compliance, which is what you were asking. And that's a task which we would like to get community health workers to assist us with, because we're familiar with the challenges. So we're trying to reduce the unrecovered meds, and they can be redistributed. But once they've been opened by a patient or taken by a patient, it's illegal to recycle the medicines. So I think... yeah, so I think DG, I've covered the questions you wanted me to.
No, thank you very much, colleagues. I'll be very quick to